Hi everyone, I'm Dr. Roman and I'm a board certified hematologist oncologist, and today I figured we'd talk about prostate cancer. Now, the first thing I want you to know is that this is a very lengthy topic. So I'm going to try to keep it very simple. This talk is gauged more towards patients and family. This is not really for healthcare providers because I'm only going to go over the basics. Now, I promise you, if you stick with me and you hear this entire presentation, I'm telling you, you will know a lot more than you do now about prostate cancer. My whole goal here is for you, when you go see your oncologist or your urologist, that you are aware of the fundamentals, the basics, so that you're not lost. And I can tell you from experience, I treat prostate cancer patients all the time, and I get asked the same types of questions. So believe me, there's a good chance that I will cover many of the questions that you may have. So before I get started, I want you to know that every single patient is unique. And remember, I do not know the specifics about your case. So this is only to basically provide a little bit of education. I am not giving any specific medical advice because, again, I'm not your doctor. I do not know your case. So always stick to whatever your doctor is telling you. So with that being said, let's get started. I've compiled here a list or a table of everything we're going to go over. And I'm telling you, there's a lot that we're going to cover. But I promise you once again, you will really know the basics. So when you do go see your doctor, you will not be lost. So let's get started here. So the first thing we're going to talk about is your PSA. Now, your PSA, also called your prostate specific antigen, is a simple blood test. That's all it is. Now, we use the PSA as a screening test. Okay, so if you're a healthy individual, once a year, you'll go see your doctor and they may order a PSA. Now, if your PSA comes back elevated, or if you're having urinary difficulties, or if you're having blood in your urine, or if you have an abnormal digital rectal exam, okay? Believe me, when I have to perform these tests, I always tell patients, believe it or not, it's probably just as painful for me to do it on you than it is for you to have it done. So, but unfortunately, it's something that us guys need to have because it can really help us identify a prostate cancer. Now, if the PSA comes back elevated, then that is a potential finding that you may have something going on in your prostate. Now, it could be a simple BPH or benign prostatic hypertrophy in which your prostate gland is simply swollen, or you may have an infection in your prostate gland. So do not think that an elevated PSA means that you have prostate cancer. But on the other side, if your PSA is normal, this does not exclude that you may have underlying prostate cancer, because unfortunately, not all prostate cancers make PSA, although the majority do. So always keep in mind that, just because your PSA is normal does not mean you may not have prostate cancer. And that's why other modalities like the digital rectal exam is usually used during screening, or just to make sure your prostate gland is okay. Now, if your PSA is elevated, then the next step is most likely a prostate biopsy. Okay, so this is what we're going to cover now. This is a test that's performed by your urologist, where they go in there and they take a biopsy or several biopsies of your prostate gland. And the whole idea here is to obtain a little bit of tissue, have it analyzed under the microscope by a pathologist, and determine if you do or you do not have prostate cancer. Now, if you do have prostate cancer, or you know a person who does, and that's why we're watching this video, correct? Then I want you to be able to have some basic knowledge on how to interpret your pathology report. So if you find this report, then you'll notice over here on this side, you'll probably see this picture. And this just means that they obtained, usually it's about 12 biopsies of your prostate, and they randomly obtain them. So let's say the prostate gland is a walnut-shaped organ, and what urologists tend to do is they'll tend to try to take biopsies in all of these areas here. And then, so it's usually A, B, C, D, E. If you look at your pathology report, or 1, 2, 3, 4, 5, those are all the biopsies that were obtained. And then it'll give you the number of biopsies that were positive or negative. So let's say this one was positive, this one was positive, and this one was positive. So then you'll have 3 out of 12 positive biopsies. Now, it'll also tell you what percentage of that biopsy was positive. So let's say you get, let's magnify this. So let's say this was the size of the biopsy. And let's say that they found cancer over on this little corner here. So they'll give you a percentage. So maybe they'll tell you in this case, 30% of that biopsy was positive for cancer. So again, you want to look at how many of these were positive as a number. So let's say 3 out of 12 were positive. And on each one of those 3, what percentage? So of course, it's common sense. The more biopsies you have positive, or the larger percentage of each individual biopsy, the more cancer in each of those little biopsies, the worse off that is. Now, you will also notice that they give you a Gleason score. And this will look something like a 4 plus 3 or a 3 plus 3, and it'll equal a number. And each biopsy will give you a Gleason score. So you may have, let's say in this particular case, this may be a Gleason of 6, this may be a Gleason of 7, and this one here may be a Gleason of 8. So we always take the higher number as what we're going to use for treatment. So in this case, you had 3 positive biopsies. Each one had an individual Gleason score, 6, 7, and 8. Now, the Gleason score simply means how ugly or aggressive this tumor looks under the microscope. The higher the number, the worse. So overall, a 6 and below is better. A 7 is intermediate. And then 8 or above is more aggressive. It's worse. And this is important because we use this to gauge basically how to follow patients, how to risk stratify patients into how aggressive this tumor is or will behave, or potentially will behave. So with that in mind and some other factors, again, I'm just trying to go over the basics here. We will stratify patients into either low risk, intermediate risk, or high risk. Now, low risk simply means that there's a chance or a likely chance that this tumor is not going to grow very fast. It's not going to spread very quickly. So it may give us a little more time. Whereas if you have a high risk tumor, that usually tells us that this tumor is more likely to grow fast, to spread quicker within the body, and have a more rapid doubling time, or a growth rate, if you will. And this is important because we use all of this information into making treatment decisions, okay? Of course, the higher the risk, the more aggressive we want to be with treatment, and the earlier we want to implement therapy on. So again, we'll take the Gleason score into consideration. We'll take the number of biopsies, and the other thing we'll take into account is your PSA. So the higher your PSA, the worse off it tends to be. So if your PSA is less than 10, we usually say that's low risk. Between 10 and 20, that's intermediate risk, or above 20, that's higher risk. So obviously, if your PSA is greater than 20, you have a high Gleason score, remember 8 or above, and you have an increased number, say you have 5, 6, 7 positive biopsies out of 12, then of course we know that that patient has higher risk disease. Whereas if your PSA is, say, a 4, you may have 1 positive biopsy with a Gleason score of 6, and the percentage on that 1 positive biopsy was, say, 2%, then overall these patients tend to do much, much better. Okay, so then once we know a patient's PSA is high, or we suspected prostate cancer, they undergo a prostate biopsy, we know that the prostate biopsy came back positive, then the next step is to stage the patient. Now, before I move further, I want to mention one small thing. The grand majority of prostate cancer is an adenocarcinoma. So look at your report and it should say prostatic adenocarcinoma, or in the biopsies that they obtained, it'll say adenocarcinoma. If it says small cell carcinoma or it says some other histology, then this talk is not valid. This is only for by far the most common type of prostate cancer, which is prostate adenocarcinoma. So let's get back into the talk here. So once we know you have prostate cancer and we've risk stratified you into a low risk, an intermediate risk, or a high risk, now we want to stage you. That simply means we want to do some sort of an imaging test on you to try to figure out, is this prostate cancer local or is this prostate cancer more advanced or metastatic? Okay, and this is usually stratified according to a staging system. Stage 1 being the earlier stage, and stage 4, unfortunately, being metastatic disease. So for this, we'll usually do either a CAT scan and a bone scan. The CAT scan's more looking at the soft tissues, looking for at lymph nodes. It also looks at bone, and the bone scan, of course, looking at your bone, because prostate cancer does like to spread to bones. Overall, the way prostate cancer tends to spread is from the prostate gland. It'll spread to local lymph nodes. Okay, these are lymphatic tissue that we have around the prostate gland. It's all over our body, but in this case, this type of cancer likes to spread through our lymphatics. So we want to look at the lymph nodes around the prostate gland, in the pelvis, and in the abdominal cavity. And a lot of times we prefer the CAT scan with contrast if possible. It's a type of dye. Got to be careful, because if you have kidney disease, then we cannot give you the IV contrast. And that is, we measure your kidney function through your creatinine. So if you look at your blood test, where your PSA would be, for example, there should be another one that's called your serum creatinine. And if it's normal, then you're good. If it's elevated, you got to be careful, because this contrast can further impair your renal function. The bone scan contrast usually does not affect your kidneys. Now, another option would be a PET scan. Now, there's the regular PET scan where they inject, it's a sugar compound with a fluorescent dye, and wherever there's cancer, this will light up, okay? Because cancer will eat the sugar, and this will cause your fluorescent moiety or your fluorescent molecule to intensify, and you will be able to detect it on a PET scan. Now, the problem here is, number one, I have seen cancer that is not detected by a PET scan. So just because your PET scan is negative does not mean you do not have cancer. Also, in order for the cancer to be seen on any one of these imaging tests, especially a PET scan, it has to have a certain size, because if it's very tiny, you may not detect it on the PET scan. Usually the cutoff is about 0.5 centimeters. Now, I've seen 0.3, 0.4 centimeter lesions detected on a PET scan, so it really depends on the actual PET scans. There are some that are better than others, but overall, just because your PET scan is negative does not mean that you are 100%, that we are 100% sure that your prostate cancer has not spread. And this goes for any cancer, by the way. None of these tests are 100%. The other thing is, just because your PET scan is positive does not guarantee that you have cancer, because anywhere where you may have an infection or inflammation, for example, a fracture site, an active abscess, any one of these can also give you a false positive PET scan. So just things to keep in mind. Now, there's another type of PET scan which is more specific for the prostate gland. It's called the PSMA PET scan. It's a very good test. It's not widely available in many centers. Even though it's becoming a little more available nowadays, but just know that there is a specific type of PET scan for the prostate gland that's called the PSMA, and if you're able to have this test done, then that might be the way to go. Also, an MRI scan, sometimes if the urologist is evaluating you, for possible surgery, they may order an MRI of the pelvis just to get better anatomy of this site. The MRI scan is the one that's noisy. A lot of patients have difficulty with it, especially if they're claustrophobic. The good thing about the MRI is that it does not give off any radiation, whereas the other tests, the CT, bone scan, and PET scan, do give off some radiation. Again, it's a small dose, but just something for you to keep in mind. And it's also important to know that if you have repeat tests, okay, like a lot of cancer patients do, I always try to keep track of how much radiation we're actually giving or providing with all of these imaging or diagnostic tests. Now, once the staging is done, we will know or have a very good idea if you have localized prostate cancer, or do you have more advanced prostate cancer or metastatic prostate cancer. That I encourage you to find my video on metastasis, and it'll explain to you a little more what metastasis is. But this basically means that your cancer has spread from the prostate to another area of the body. And usually this means that now we're only going to treat you palliatively. In other words, we're going to extend your life, but there's no chance of a cure. Now, there are some exceptions, and I don't want you to get all depressed if you do have metastatic disease, because prostate cancer is one of these cancers that I have several patients that live many, many, many years. And it all depends on all the factors that we're covering on here. So just because you have metastatic prostate cancer does not mean you're going to die anytime soon. So please hang in there, educate yourself, because it might not be as bad as you think. Okay, hopefully I'm encouraging you here a little, and I'm not lying to you. I'm giving it to you as it is. And again, I have this conversation with patients all the time. So here we've determined, do you have localized disease where we can try to cure you, or do you have metastatic disease in which there is no chance of a cure, and our goal here is going to be to extend your life. Now, once we have all that information, the next question will be, what is your life expectancy? Before, we used to go more by age, but now we really don't go by age. We go more by what we call performance status. And that means how good does the patient look? I mean, I see people who are 60 and they have diabetes, they've had 3 heart attacks, they've had 2 strokes, they're in a wheelchair, they look awful. And I'll have a patient who's 85 and they're playing tennis. They look wonderful. So we're not going to treat those 2 patients the same, even though one is 85 and one is 60. No, we're going to take each individual patient depending on their performance status or the way that they look, and we're going to try to estimate what is their life expectancy. So if your life, or overall in prostate cancer, we try to divide patients whose life expectancy is likely to be less than 5 years, between 5 to 10 years, or possibly above 10 years. Now, at the end of the day, we never, we're not God, we're not Mother Nature. We do not know exactly how long you're going to live. But I can tell you, if you have, say, you've had 5 heart attacks and you're in a wheelchair, you've had 2 strokes, there's a pretty good chance that you will not be alive beyond 5 years, although you may be one of those exceptions. But we need to know this, because are we going to give you aggressive treatment? Is it worth submitting a patient or providing all these treatments where they may suffer a little bit, and then once they improve from all of these treatments, then they may unfortunately pass from something else within 6 months. So we always got to keep all this in mind, and we do, to make a decision on how we're going to proceed with treatment. So if the patient's life expectancy is less than 5 years, a lot of times we don't do anything unless the patient has very advanced cancer or has pain or has symptoms that, of course, we're not going to leave a patient suffering and in pain. We're going to provide some treatment for them. So, but if you have a patient that doesn't have, they may have advanced cancer or they don't have advanced cancer, but they have a lot of medical problems and their life expectancy is less than 5 years, if you think we can leave you alone, then that is usually what we recommend, okay? Now, if your life expectancy is beyond 5 years or definitely beyond 10 years, then it might be worthwhile treating you. Now, I just want to go over these two things here called castrate-sensitive prostate cancer and castrate-resistant prostate cancer, because this might be something that your urologist or your oncologist will bring up. So Prostate cancer feeds off of testosterone. That's right, the male hormone, what gives you strength, that is what feeds usually the prostate cancer. So some of the treatments that we provide are blocking your testosterone level. So either we block the testosterone receptor or we decrease the amount of testosterone in your body. So in essence, we're removing the food that the prostate cancer eats. So we're kind of starving the prostate cancer. So if we reduce your testosterone level, then your prostate cancer will not have anything to eat and it will start to shrink. It will start to die off. It'll start to basically become very malnourished. And we can see this because the prostate cancer starts to shrink if we provide follow-up imaging, say CAT scans, bone scans. A lot of times you'll see that the size and the number of your lesions will decrease. The other thing we will see is if your prostate cancer produces PSA, remember, not all prostate cancers produce PSA, even though the grand majority do. If your PSA level starts to decrease, then we obviously know that the volume of prostate cancer is decreasing. It just makes sense. What makes your PSA is your prostate and the prostate cancer. If the amount of prostate cancer in your body is shrinking or reducing, then the level of PSA will start to come down. And that's one of the ways that we know that you're deriving benefit from treatment. Now, by decreasing your testosterone level, unfortunately, that's where a lot of the side effects come. For example, if you've been on treatment for prostate cancer, the hot flashes, the sweating, the bone loss, the weakness, the muscle loss, the breast sensitivity, or your breasts start to grow. It's what we call gynecomastia. There's a whole bunch of side effects that can occur. A lot of times they're mild, but sometimes they can be quite significant. And sometimes we have to modify treatment because patients tell me that it's basically really ruining their quality of life. So in those cases, we have to change treatment. But just know that the whole goal here is to reduce your testosterone level. So if I'm giving you testosterone blocking agents and your testosterone level goes down and your PSA improves, your cancer improves, then you have castrate sensitive prostate cancer. Think about it. The name is telling you castrate sensitive prostate cancer. By giving you these medications, we're reducing your testosterone level. We are providing chemical castration. Sometimes instead of giving you the shots or the pills that reduce testosterone levels, you may go in for a surgical castration where they remove your testicles. You're basically doing the same thing. You're just reducing testosterone levels. Now, there are times that your testosterone levels are very low. And that's what we do, by the way. When we start you on these treatments, we will measure your testosterone level. And usually we like to see it below 50. And I'll tell you, I like to see it below 20. So 20 is my go-to, 20 or below. A lot of times patients will have PSA testosterone levels that are 2, 3, 4, 5. And that just tells me that the treatment we're providing is really depleting the testosterone level. It's doing what it needs to do. So that means if we're giving you these medications, testosterone's coming down, your PSA is coming down, your prostate cancer is coming down, obviously you're sensitive to the castration treatment we're giving you. Now, there will come a time, or there may come a time, that even though we're giving you these treatments, your PSA starts to go up. So you'll say to yourself, well, wait a minute, I've been on treatment maybe 6 months, maybe 6 years. Everybody's different. And all of a sudden your PSA starts to creep up, or on an imaging test, CAT scan, for example, the number of lesions or the size starts to increase. And your oncologist will tell you, well, you know what? The treatment is starting to fail. The treatment is not doing what it needs to do. And that's because your tumor is developing resistance. Remember, instead of using testosterone to grow, it's figured out a way to use other nutrients to feed off of and grow. So that's when you develop castrate-resistant prostate cancer. That means that now things have gotten a little bit worse because just providing testosterone blockers or testosterone reducing agents is not good enough. We have to go to plan B. Now, and we'll get into this a little further when we go over all the potential treatment options. Now, I want to go over genetic testing. So there's two types of genetic testing that you can do. One is germline genetic testing, and the other is somatic testing. So germline testing simply means that we're gonna do genetic tests on you to see if you were born with a gene. That's germline. If you were born with a gene that may increase your risk of prostate cancer. There are many different genes, many of which have been attributed to multiple types of cancer, not just prostate cancer. I mean, we do this for breast cancer, for colon, all types of cancer. So one test that your oncologist might order is germline testing to see if you have a specific gene. For example, a BRCA gene. It's the same gene that some women get that may predispose them to breast cancer, for example. There are others. So do you have one of these genes? Because number one, it'll tell us that you have an increased risk of prostate cancer. Number two, you can also provide this information to family members, especially brothers, sisters, children, that, so they're aware that they may have a higher risk of cancer down the line. But also it has treatment or therapeutic implications that we will go over. The other type of genetic testing is somatic testing. In this case, we can either test the blood or we can either test the tumor, the biopsy that was done. And this simply means maybe your body, because of age or because of smoking, alcohol, environmental factors, whatever the case may be, your body developed a genetic mutation that might have caused this cancer. So it does not mean you were born with this mutation. That's germline. So could you have acquired a mutation down the line that might have caused this cancer? And again, we want to know this because some of these mutations may have treatment implications. So don't confuse germline genetic testing or somatic testing, in which case we may do a blood test. For somatic, it's either the blood or the tissue. For germline, it's either the blood or your saliva or a buccal swab. There's several ways that we can do this, okay? So now, we're going to get into treatment. And here's where the bulk of questions come in. So I hope you're still awake. I hope you're following me. Again, I know this is a lot of information, and just think about it. I'm just going over the basics. So if I've said something that you may not agree with or your doctor said otherwise, remember, every case is different. I'm just providing the basics here. So don't get discouraged. All right, now we're going to move on to treatment. So the first question we have to ask is, do you need treatment? If you're one of these people that have a life expectancy of less than 5 years, you have multiple medical problems, then maybe we really don't need to do anything. So that's the first question you have to ask. If the decision has been made that yes, you need treatment because you have, you're medically fit or you have symptoms of disease or whatever the case may be, then we need to decide, are you a potentially curative patient or do you have metastatic disease? So if you're one of these patients that has localized prostate cancer, then we can talk about potentially curing your prostate cancer. And for that, we have surgery or radiation. So let's start off with surgery. So we've gone over the observation. We've decided that yes, you need treatment. So then let's talk about surgery. Here, it can be either minimally invasive, for example, robotic. This is done by your urologist, or an open incision. Robotically or minimally invasive is usually much better, quicker recovery, less side effects, better outcomes. It all really depends on the surgeon. Let's face it, anything can happen to anybody, no matter who the surgeon is. But usually if it's a surgeon that's performing a lot of these surgeries, usually the outcome tends to be better. Now, most patients that have surgery are those that are medically fit and younger. Usually when a patient is older than 70 or they have multiple other medical problems, that they're kind of mild, intermediate, but, advanced diabetes, maybe they had a heart attack 5 years ago, but they're still medically fit, but they have other medical problems. Maybe surgery is not the way to go, and in those cases, probably radiation will be the better option. Now, I get asked this question all the time. Should I go for surgery or should I go to radiation? And now, I tend to say if you're younger or very medically fit, I tend to go with surgery. I usually recommend surgery. Now remember, this is for localized disease, because if you have advanced disease, surgery and radiation are not an option, because if your cancer has spread to another part of the body, what good is it to just remove the prostate cancer or localized when you're going to leave cancer behind somewhere else in the body? So always remember that this is for localized prostate cancer. So the important thing here is that surgery does have potential complications, you know, the pain, the bleeding. But again, as I said, if it's a high volume center, high volume surgeon, the complications tend to be less. Now, this is what I need you to always remember. If you have surgery and your prostate cancer comes back locally again, so let's say you have surgery, it's removed, and then your PSA is 0. Remember, we follow your PSA afterwards, and your PSA starts to rise. This means that your prostate cancer is coming back, and you do tests, you do imaging tests on your body, and we do not find cancer anywhere. Chances are it's coming back in the prostatic bed. In other words, the area that you had surgery, around that area, chances are the cancer is coming back. And in those cases, we can give you radiation, okay? Now, if you have radiation first and your cancer comes back, very rarely will a urologist touch you. So very rarely will you find somebody that will be able to resect or have surgery afterwards. So I'm going to repeat this because this is very important. If you have surgery and your cancer comes back locally, then radiation is a potential future option. Whereas if you have radiation first and the cancer comes back again locally, chances are you will not be a surgical candidate. So just something to keep in mind, because that's why I tend to recommend surgery first if you're fit for surgery and you have a urologist that's willing to do surgery on you, because it gives you that second option. Something I'll take time here. If you have surgery and they go in and they resect this, and let's say that you had more disease than what they expected, or your margins are positive. In other words, your urologist went in there, took out the prostate, but they tell you that prostate cancer cells were left behind, then they may give you radiation afterwards. Okay, that's another option of radiation. It really gives you, you're obtaining more tissue. It's giving you a clearer picture as to how much disease you had. Because remember, all we're going by are your prior biopsies, in which we randomly obtain usually 12 biopsies. If they go in there and they remove the whole prostate gland, we're going to have the whole gland that we can analyze and then get a better idea as to what or how much volume of disease you had in your prostate gland. So let's talk about radiation now. So just know that there are overall 2 types of radiation: external beam radiation therapy and brachytherapy. Again, I'm trying to keep it simple here. I can go on talking about this for an astronomical amount of time, but again, my goal here is for patients and families, so I want to keep it simple. So let's talk about brachytherapy. These are the seeds or the pellets that they put in that contain radiation. This is for localized prostate cancer. It's works very well. I found that this works more for patients who have a little bit of disease or lower risk disease. Patients who have a lot of disease, in my opinion, this doesn't work as well, even though we have newer literature now that because of improved techniques, patients are doing better even with more advanced or more aggressive prostate cancer. But overall, I tend to reserve brachytherapy for patients who have a little bit of disease. Now, if you have brachytherapy, in the future, you could potentially have external beam radiation therapy, which means a more aggressive form of radiation on the outside of the body. Now, let's talk about that, which is the external beam radiation therapy. There's different types of external beam radiation therapy, and this is a conversation to be had with your radiation oncologist. And if you have a question about radiation, go seek an opinion from a radiation oncologist, because they are the specialists. So remember, you have your urologist, your medical oncologist or hematologist oncologist. That's, for example, me. And then you have your radiation oncologist. So don't confuse these specialists. Totally different specialties. The oncologists, such as myself, we're the ones that can provide the anti-hormonal treatments. We can provide chemotherapy, immunotherapy, a bunch of other treatments, which we will go over. So going back to the external beam. So basically this is usually given Monday through Friday, a lot of times 5 to 6 weeks. And again, this is given for localized prostate cancer, because once you have metastatic disease, again, why are you going to treat something locally when you have cancer outside the prostate at a distant site? Remember, if you're metastatic, usually there's no chance of a cure. So why provide all these aggressive treatment options unless you have another reason to do so? Like, for example, maybe you have a lot of blood in the urine, and then they may give you some radiation to lessen the amount of blood you have in your urine. But again, each case is unique. But overall, for metastatic disease, usually we do not give radiation therapy. Now, there may be a time where you have metastatic disease and we do give radiation therapy. And that's quite simple. Let's say you have metastatic disease to the bone and you have a lot of bone pain. So we may give you radiation to that one site to reduce the amount of cancer you have at the bone and improve your pain. But again, the goal there is not to cure, it's just to provide palliation or to provide pain relief. So again, remember, we've gone over surgery, we've gone over radiation. Radiation, we have brachytherapy, which are the seeds. We went over external beam radiation therapy. These two are potentially curative. In general, okay, usually if you have surgery and the cancer comes back locally, we can give you radiation. Unfortunately, if you've had radiation and the cancer comes back locally, usually surgery is not an option. So always remember that when deciding whether to go for surgery or radiation. Like I said before, if you're very medically fit, I tend to push for surgery. If not, I agree with radiation. Sometimes we'll combine reducing your testosterone levels, which we will go over now, with radiation therapy. And sometimes after surgery, depending on what we find, we may give you also testosterone suppression or suppressing treatment. A lot of information I'm throwing at you, I know, but if you need to pause, go back and listen to it again, because it will start to make sense once you hear it several times. So let's talk about androgen deprivation therapy. Oh, and before I do so, I just want to touch up on something, the potential side effects. So both surgery and radiation can cause a lot of symptoms. Both surgery and radiation can cause erectile dysfunction. They can both cause urinary dysfunction. It's a fact of life, usually a little more so with surgery, but radiation can also do it. At the hands of an experienced surgeon, the numbers do improve. And just know that with radiation, you're burning the area, so you may also burn the rectum, the bladder, you may develop diarrhea. And the important thing here is that you may develop side effects of radiation over a year after you've had radiation therapy. So that's right. So I've seen patients where they had radiation 1 or 2 years ago, and now they're having side effects from that radiation. It's not common. I don't see that quite often, but just know that that's something that could happen. So have that conversation, or what's the risk of you developing these side effects? And depending the type of radiation they give you, these side effects may either increase or decrease. Now, going back to the androgen deprivation therapy. So these are basically medications that we give that reduce the amount of testosterone in your body. So the whole goal here is we give you these medications, testosterone level decreases, and in doing so, we starve your prostate cancer. So the first one on the list is Leuprolide. This is a shot. It's an intramuscular shot. And it can be given once a month. It can be given once every 3 months, every 4 months. It all depends on the dose. The main thing here is the side effects. This medication will decrease your testosterone level, and in doing so, it can lead to erectile dysfunction. It can lead to hot flashes, profuse sweating, muscle loss, fatigue, gynecomastia, which is just an increase in the size of your breast tissue, or sensitive breasts. It's something that's very common with any one of these medications. So it's just something to keep in mind. This is what we call an LHRH agonist. This basically decreases our testosterone level. Now, there's something I want you to know about this. So if you look at this graph, this is your testosterone level, and this here is time, okay? And this is your level of testosterone. So when I first give you the dose of Leuprolide, okay, initially the level of testosterone will go up, and then within a few weeks, it'll come down. So this initial surge, it's what we call a testosterone surge, in which you give the medication, testosterone goes up, and then a few weeks later, it comes down. That makes me a little nervous because think about it. You're increasing the amount of testosterone in your body initially for 1 to 2 weeks. And so I don't like that. So what I usually do to block this is I will give this pill, it's called bicalutamide, and a lot of times I'll give this medication for a few months, a month, 2 months, and that will block that initial testosterone surge, because what you're doing with that pill is that you're blocking the actual testosterone receptor. So first you're blocking the receptor, so even though testosterone level goes up, the receptors are blocked. And then once the testosterone level goes down, we can measure it, but I can tell you the leuprolide works very well. Once your testosterone levels are low within a few weeks, I usually stop the pill. Now, there are times where I will continue the pill. So just because maybe you are on the shots and the pill does not mean there's anything wrong. I do this all the time. It all depends your particular case. So a conversation to be had with your oncologist. Now, the bicalutamide, like I said, it's a pill. It can also cause side effects, the gynecomastia, the hot flashes, all these types of things. Although I noticed from experience that the shots do it more so than the pills. Now, the bicalutamide is a first generation anti-androgen. I need you to remember that. That's a first generation anti-androgen. Whereas these medications here, I'm just going to clump them all together for simplicity. I'm trying to simplify things here. These are second generation anti-androgens. Now, remember when we went over the castrate resistant and castrate sensitive prostate cancer? Usually these medications from here up, we start giving when you have castrate sensitive prostate cancer. Okay? So in other words, we want to give it to you because we want to decrease your testosterone level. We give it to you, your PSA starts to come down. So let's say down the line, 6 months, 6 years, I mean, everybody's different, your PSA level starts to go up, even though your testosterone level is low. You have developed castrate-resistant prostate cancer. So in this particular case, we know that the shots by themselves, or the shots and the bicalutamide, is not working. So we need to go to plan B. And in that case, that will be one of these medications. So in this case, we stop giving the bicalutamide. We always continue the leuprolide. Now, there's an exception here, and I should have mentioned this earlier. And if you've had an orchiectomy or your testicles have been removed, remember the shots, what they do is that they provide, it's a chemical castration. So if you have had a surgical castration, then it's the same thing as having the shot. Okay, so, but that's very rarely seen. I think I've seen maybe 5 my whole life. The majority of patients have chemical castration with the leuprolide. So the leuprolide is going to be continued throughout treatment. So always remember that. The shots usually, there are times we have to stop it, but usually the shots continue. What we will change is from a first generation anti-androgen to a second generation anti-androgen. And then we start either the abiraterone, apalutamide, enzalutamide, there's several out there. So we'll give you one of those treatments. Again, those have similar side effects. There are some other side effects, very rare, like mentions of seizures, or again, every medication has potential side effects. That's beyond the scope of our talk today. But just know that when you develop castrate-resistant disease, then we'll start giving you one of these medications. Once we give you, say, abiraterone, and down the line it stops working because your PSA starts coming up again, then we'll change you to another one, and so on and so forth. So I want to also take the time now to tell you there are times that patients have castrate-sensitive prostate cancer. Okay, so think about it. It's in the earlier stages. Okay, it's still responding to testosterone blockade. And there are times that we give these medications. So don't think that just because you're on one of these medications, you automatically have castrate-resistant prostate cancer. That may not be the case, because there are times that we use them in both. Again, I'm trying to keep things simple here because there's a lot of information, but I'm trying to break it down as clearly as I can, so when you go see your urologist or your oncologist or your radiation oncologist, you know what you're talking about. So once these medications have stopped working, so for example, they started the leuprolide, it all of a sudden your PSA started to go up, or they're on leuprolide and bicalutamide, the first generation anti-androgen, your PSA went up, you developed castrate-resistant prostate cancer, then we went into the second generation anti-androgens. You were on these pills maybe for 6 months, a year, 2 years, 3 years, whatever. I mean, I've had patients on these medications for years. I've had some patients that within a few months of each, they start progressing. Unfortunately, their cancer grows. Some patients just have more aggressive cancer than others. Then in those cases, usually it's time to move on to chemotherapy. Now, chemotherapy is a medication that will decrease your testosterone, it'll decrease the volume of cancer that you have. There's cytotoxic chemotherapy. This is the big gun now. This is the one that, takes your hair out. These are the ones that have side effects of they can decrease your immune system. They can increase your risk of infections. And they're not necessarily better than the anti-hormonal treatments above. They're actually not. Chemotherapy, once a doctor tells you that it's time for chemotherapy, usually it's a little worse off. Things are starting to get a little more serious now. So usually the first chemotherapy drug we start off with is docetaxel. Again, usually your hair will fall out. They may give you a shot that's a GCSF. It's basically a shot after chemo, usually 24 to 48 hours after chemo. This is to boost your immune system. And usually this is given every 21 days. So we'll give you this treatment, and down the line, if your PSA starts to rise again, then we know that whatever, in this case, docetaxel, stopped working, then we'll move on to your second chemotherapy agent. In this case, cabazitaxel. And then that'll work for a certain amount of time. Then we'll move on to mitoxantrone, even though mitoxantrone is something that we very rarely use because it's quite toxic and, in my opinion, not that good. But I have used it on occasions. Again, you have to take things on a case-by-case basis. Now, just know that each chemotherapy drug works differently on each patient. I've had patients that do very well with chemotherapy. I've had others that don't do quite well. Some patients tell me that they develop mild side effects. Some patients develop a lot of side effects. So it really depends. Now, there are times, again, trying to keep it simple, but just so you know, there are times that there are patients, for example, that may have metastatic cancer, and we're giving them chemotherapy together with hormonal therapy earlier on. That's usually on a patient, for example, that is on the shots, and they may have a lot of cancer, and then we may give them some chemotherapy as well to try to shrink fast the amount of cancer they have. I'll give you a typical example. You have a person who unfortunately has extensive metastatic prostate cancer. They have a lot of pain. You put them on one of these testosterone blocking agents, usually the shot, which is the leuprolide, and I'll give them chemotherapy because what I want to do is to try to shrink that cancer really fast to try to improve their symptoms. I want that pain to try to go away. Again, with the second generation anti-androgens, we can also do that. So a patient that has metastatic disease, maybe we just don't want to have them on leuprolide by themselves, so we may add one of these second generation anti-androgens to try to shrink that tumor as fast as possible. So again, small recap here. Localized disease, surgery, radiation, metastatic disease. We usually do not go for surgery and radiation therapy. We want to reduce their testosterone levels. Usually, on a case-by-case basis, there are patients who have very little disease that maybe we won't do anything. But again, we want to reduce the level of testosterone. We want to starve the prostate cancer. And when one treatment stops working, either because you see the tumor growing on film, on the CAT scan, on the PET scan, etc., or the PSA starts going up, then we go to the second treatment. So for example, leuprolide in the first generation, then we may go to second generation anti-androgens. Sometimes we'll give one second generation anti-androgen. If that stops working, then maybe we'll jump to the next second generation anti-androgens. Once those stop working, then probably time to go to chemotherapy. And then we'll usually go to 1-2 chemotherapy agents. And if the patient is medically fit to continue treatment, then we will continue. Sometimes, unfortunately, patients are too beat up on, if you will. They're just very sick, and we realize that we are providing more damage or more harm than good. And in those cases, we will recommend, listen, it's time to stop the madness and proceed to hospice. And hospice is a very good service that they provide. If you don't know what hospice is, I encourage you to find my video on hospice care, because it's something they really do provide a good service. And unlike a lot of people who say, oh, hospice will just kill you faster, that's not true. I have placed some of my family members in hospice because there will come a time in most of our lives that we will have to decide, because we all die. And it's just when and how. And I can tell you that for the most part, patients in hospice suffer a lot less than patients who do not seek this service. Now, let's move on to immunotherapy. This is not used that often, but remember when earlier in the video we discussed genetic testing and we went over somatic genetic testing. In these tests, a lot of times they will look, there are tests, I'll just mention some here. If you have microsatellite instability or microsatellite unstable disease, or if you have a high tumor mutational burden, again, I know this is Chinese, I'm just letting you know there are tests out there on these genetic tests that will tell us if the immunotherapy is likely to provide a benefit. And if the answer is yes, then your oncologist might recommend immunotherapy. Because if you don't have these, chances are the immunotherapy will not work. Even if you have these, there's still a chance that the immunotherapy might not work. So don't think this is not a magic bullet, it's just another potential treatment option. Now, the way immunotherapy works is that it simply stimulates your immune system to attack the cancer cells. Sometimes it does, sometimes it does not. Now, on rare occasion, in stimulating your immune system, that immune system may also attack your body, and it may cause what we call an itis. So it may cause inflammation of your lungs, a pneumonitis. It may cause an inflammation of your colon, a colitis. And if it's of the lung, you'll just develop a lot of coughing. If it's of the colon, you'll develop massive diarrhea. We got to be looking out for these, because if you have this, then we need to stop treatment immediately and start you on a medication known as steroids. So again, just another potential treatment option. Another treatment option are nuclear medicine treatments. There are several out there. Again, that's beyond the scope of this book, but if you have metastatic cancer, you've been, metastatic prostate cancer, you've been on multiple treatment options, just ask your oncologist if one of these nuclear medicine treatment options is a potential treatment option for you. Again, there's good data on some of these, but they also have known side effects. So some patients qualify, some do not. The last treatment option I want to go over here are PARP inhibitors. Now, remember when we went over the genetic testing. Now, in the germline genetic testing, remember whatever genes you were born with, which most people are not born with some of these cancer genes. Thank God most patients are not, but there are patients that are born with some germline mutations. Or there are some somatic mutations, some mutations that you acquired because of age or because of smoking, lifestyle, environmental, whatever. So again, germline you're born with, somatic you acquire, you develop with time. And there are some mutations which if you have, I'll give you the most common, is the BRCA, the BRCA gene. If you have this mutation, then you might be a candidate for a PARP inhibitor. Again, not a magic bullet. Chances are it's not going to cure anybody. It's another treatment option. They do have side effects, but again, once you have metastatic disease, it's all about extending your life and providing quality of care. So I think we've reached the end here. Again, there's a lot of information. A repeat here. I am not your doctor. Everybody is different, but just a quick recap that I want you to take home. The most important questions I get asked here is the PSA, Follow the PSA. Not all PSAs not all tumors produce PSAs. Not all prostate cancers produce PSA, although the majority do. Also remember that you want to look at your pathology result, and at least with these basic points that I gave you, you will really be able to have a nice conversation with your doctor about what type of prostate cancer do you have. So do you have low risk, intermediate risk, or high risk? Then you want to know, do I have metastatic disease or do I have local disease? What imaging test did they do on you, okay, to see if you have metastatic or local disease? What's your life expectancy? Depending on what that is, do you need treatment or not? If you have local disease, surgery, radiation. If you have more advanced disease, then we'll go to hormonal treatment and all the other treatment options that I mentioned. And remember that whether you have castrate-resistant prostate cancer or castrate-sensitive prostate cancer, a lot of these treatments, we jump around. We may use some of the second-generation anti-androgens or chemotherapy, even in castrate-sensitive prostate cancer. Remember what I told you about surgery and radiation. If you had surgery, you'll be a candidate for radiation down the line. If you had radiation, chances are you will not be a candidate for surgery. So thank you for your attention. Again, this was a lot of information. I am a practicing physician. That's why I just use basic stuff here. I don't do the fancy editing. I don't have the time to do so. My goal here, honest to God, is to help you out. I mean, I find enjoyment in being able to help patients. I've had family patients with cancer. And, you really start to feel desperate. And, as a fellow human being to another, my ultimate goal here is really to help you out. And if I have time and I see your comment, I'll do my best to be able to answer it for you. So thank you. And if you like, please subscribe. I'm going to be coming out with other content. And thank you for your attention.